After seeing so many adjunctive therapy, I will focus on the conjunctival autografts and especially what is ideal conjunctival autograft. I have no financial interest in any of the products. So why conjunctival autografts? The pterygium excision with conjunctival autograft is the procedure of the choice nowadays for the treatment of primary as well as recurrent pterygium because of its efficacy and long-term safety. A free conjunctival graft is harvested from the superior or supratemporal bulbar conjunctiva and is sutured in place over the bare scleral defect. This is the upper photograph showing the primary pterygiums, and we have harvested the conjunctival autograft from the superior conjunctiva, and we have secured the graft in place over the bare sclera. So why conjunctival autograft? Because it has the lowest rate of the recurrence, as low as 2%. It has minimal side effect and complications. It's cost effective, better post-operative comforts, and better post-operative cosmesis. So what is an ideal conjunctival autograft? It should be as thin as possible. It should be completely devoid of any 10-ounce capsule. There should not be any buttonholing, and size and shape should be same as the bare scleral defect. And orientation is very important. The limbal side of the graft should be towards the limbal side of the bare scleral defects, and the epithelial side of the graft should be towards the surface, and the stromal side towards the bare scleral defect. Now coming to the harvesting of the autograft, we should measure the area of the resection. We pull the eye downwards, and some kind of a marker we can use, either Janssen violets of the marker pan, to mark the area. And central mark is also important to help the orientations. We inject the subconjunctival 2% xylocaine with adrenaline with 26 or 30 gauge needles to separate the conjunctiva from the 10-ounce capsule, and we carefully dissect the conjunctiva using the Vanna scissor. And we should make the graft as thin as possible, avoiding the buttonholing. This is to show how we measure the graft and the marking. And the central marking is also important for the orientation, whether which is the epithelial side and which is the stromal side. Now, alignment of the graft. We slide the conjunctival graft on the cornea and then into the scleral bed with care that limbal side of the graft remains towards the limbal side of the bare scleral defect. So we have to be very careful. Also, care should be taken such that epithelial side of the graft remains towards the surface and the stromal side towards the bare scleral defect. So the central marking helps in this. Now, how we secure the graft? We can either suture with 10-0 nylon or 10-0 Vicryl sutures, use of the Febrin glue, and nowadays we are using the autologous blood also. Now, suturing of the autograft. We secure all the four corners with the scleral bite. We avoid the medial rectus area to minimize the bleedings. Close the nasal conjunctiva to the conjunctiva graft, and no scleral bite is taken here. We close edge to edge superiorly and inferiorly, and there should not be any exposed 10-ounce capsule or coming through the graft and conjunctival junctions. And do not advise the running sutures generally. Bandage contact lens we can apply after securing the graft. It is more comfort for the patients and no patch is needed. And we can leave the BCL for 2 weeks, and it also decreases the chance of the Dellen formations. This is the very small video clips showing the conjunctival autograft with suturing. Video is not playing. Sorry, this video is not playing. I will try this. Yeah. This is another with the conjunctival autograft with the fibrin glue. This was the case of the recurrent pterygiums. And after the pterygium excision, we have to mark the defect. This is the injection of the subconjunctival xylocaine. And then we carefully dissect the conjunctival graft. This video is stuck. Yeah, I'm sorry, the video was not playing properly. In the upper photographs, we can see the conjunctival graft was firmly attached to the underlying sclera using the fibrin glue. And this was the 1 year down in the line. We can see the well-taken graft. And in the lower picture, we have used the suture for this, securing the conjunctival graft. And also the 1 year, it's very good. But conjunctival autograft is also not free of the complications. There can be the chance of the recurrence, inflammations, infection can be there, bleeding, Dalen formation is sometimes common, and granuloma formations can be there. We have not taken care of the Tenon's capsule. These are some of the complications of the conjunctival autograft, like graft inflammation, edema, graft necrosis, Dalen formations, and the recurrence of the pterygiums. So to conclude, the pterygium excision with conjunctival autograft is the procedure of the choice for the primary as well as recurrent pterygiums. Ideally, the graft should be thin and devoid of Tenon's capsule. It should be of the same size and shape as of the scleral defects, and it should be aligned properly. Also, the graft should be secured well in the scleral bed, either with the sutures, fibrin glue, or autologous blood, whatever we are comfortable with edge-to-edge appositions. Thank you very much.